Hello, everybody. Welcome back to the Incubator Podcast. We're back today for an episode of Journal Club. Daphne, how's your summer going?
Phew, summer going, it's gone.
That's right.
Sadly, but we had a very nice summer. Um, Catching up on some of these papers that we didn't get to this summer. We had quite a
Correct.
backlog, I think.
Yeah, the folder is full.
Yeah.
That's for sure.
We'll need to
Uh,
do an extra journal club. It looks
yeah,
like our
we.
colleagues are quite prolific even over the summer.
That's right. That's right. Um, I hope that the audience has enjoyed the series of episodes that we've released so far over the summer that have a very um, educational flavor. I guess we've really been intentional in delivering content that is very diverse and that would be quite relevant for a new crop of budding neonatologists joining the
Mhm.
force. And for everybody else, I think I enjoy these episodes tremendously as well. And
Absolutely.
I'm not in fellowship, but so I think that's good. Also, just a quick mention: the two great episodes that we had, I believe it was last week, that we've done in collaboration with the Neck Society. Um, if you are interested in learning more about Neck and fostering collaboration for research and advocacy, then definitely check out the 2025 Neck Symposium. You can register. I believe that the next symposium will take place. I know the next symposium will take place during September, near September 7 through 10, I believe. And you can learn more at nextsociety.org/neck-symposium. If you're going to register, you don't forget to use the incubator code for 10% off. So you just write incubator and you should get some discount on your registration. I think that does it. We have an EBNEO segment today. Very excited about this ongoing collaboration we have with the evidence-based neonatology team. And I don't think that's much more for the announcements. I would say if you have a few minutes, check out our website and check out the delphiconference.org website. We have an updated agenda with pretty much a full agenda now. It's very exciting. We've been eager to release that. And the conference will take place January 26th through 28 in Florida. So if you want to catch some sun in the middle of the winter, please come visit us. Tickets are already available, and I think some people have already started purchasing.
Mhm.
So definitely check this out. Definitely, I think we can start, huh?
I think that's all the housekeeping tasks for today.
Yeah, yeah, for sure. Okay. So I guess the first place I'm going to start with is some new Fenton growth curves have been published. And we use the Fenton growth curves every day in the NICU, and it's always a big deal when an update to tools that we use so frequently in the NICU are published. So I'm going to start, I guess, with a pair of papers because they're both from the same author, from the Dr. Fenton, and they're published a couple weeks back, and it's a major update to something that we rely all day in the NICU. So these new third generation Fenton growth charts represent, I guess, a change in how we evaluate growth in preterm infants. I think for many years, the Fenton curve has helped us approximate what a baby's growth would look like if they had continued developing in utero. And the goal has always been to nourish preterm infants in a way that mirrors what normal fetal growth has always been. But achieving that goal does require that data from this chart that truly reflects what healthy growth does look like. Previous Fenton charts, especially the second generation edition, relied heavily on population level data that included many infants with abnormal fetal growth. And these were babies born due to growth restriction, preeclampsia, maternal diabetes, and other complications that inherently skewed growth patterns. And so as a result, the lower percentiles on those charts were flattened and shifted downward, especially when we were talking about babies that were between 22 and 28 weeks. And that's the gap that these two new papers set out to address. The first is published in a journal that I don't usually consult. It's called Pediatric and Perinatal Epidemiology. And that paper actually provides the scientific and statistical foundation for the updated curves. It describes basically a meta-analysis that is being done and the modeling techniques that were used. The second paper is published in a journal that we more commonly visit, the Archives of Disease in Childhood, Fetal and Neonatal Edition, and it presents the final version of the charts for clinical use with new tools and practical recommendations for charting growth in the NICU. Now, together, these two studies offer both a rigorous background and a ready-to-use implementation, because obviously we can look at the Fenton growth standards. So let's start with the methods. So they conducted a systematic review and meta-analysis under the PRISMA guideline. They searched, pulled data from Medline, Embase, graded literature via Google, the US Vital Statistic Database, the INEO Consortium, and they included studies published before 2013, the time of the last chart update, through to November 2024. Now, to make sure the new charts truly reflected healthy fetal growth, they use strict inclusion criteria. And I think that's the key to the difference between these new updated curves and the old ones. So they only used population-based cohort of preterm infants born at 22 to 42 weeks gestation. Only infants without abnormal fetal growth were included, and they excluded cases of congenital anomaly, hypertensive disorders of the mother, gestational diabetes, smoking, and provider-initiated preterm birth. Inclusions only of studies with at least, and they included only studies with at least 500 infants born before 30 weeks. Now, in total, 7 studies were selected spanning 15 countries, over 4.8 million births, including 174,000 infants born before 30 weeks. The researchers extracted numerical data for weight, head circumference, and length. They stratified these by sex, and these data were harmonized with WHO standards and smoothed using advanced statistical modeling, including cubic splines. Age was adjusted from completed weeks to daily interval, with each completed gestational age week shifted by 0.5 weeks to allow real-time plotting. Now, in the final implementation paper, the team introduced a small but clinically important change. They applied a 1.5% postnatal weight reduction for infants born between 23 and 32 weeks to reflect early weight loss from fluid shifts. And we'll see this in the curves. I'm going to show you that, Daphna, on the video. If you're watching this on YouTube, you're going to be able to see this. This was based on clinical consensus, particularly for plotting SGA infants and aligning growth expectations during the early postnatal period. The modeling approach emphasized visual assessment of percentile across gestational ages to ensure the curves were both smooth and clinically realistic. So let's talk a little bit about the results. What did they find? I would say that we can divide these findings into 3. Number 1, they found more consistent growth across percentiles. Compared to the second generation Fenton charts, the third generation curves showed more uniform and realistic growth patterns across all percentiles, including the lower end. So in previous chart, the 10th percentile flattened between 22 and 28 weeks and steepened again around 30 to 36 weeks. In contrast, now the new 10th percentile line follows a more consistent trajectory. In fact, at 28 weeks, the new 10th percentile matches up with the 27th to 29th percentile on the old chart, meaning that the older curve may have actually underestimated growth for some preterm infants. I'm sorry, I think that's quite interesting. So actually, let me pull these up for you, Daphna, so you can actually take a look. And I'm gonna share my screen here, but yeah. But it's very nice, actually, if you look at the different figures. So in the Journal of Pediatric Perinatal Epidemiology, they have actually the growth curve, and they have actually plotted the new Fenton chart over the
Uh-huh.
old ones. And I think that it's very interesting to see. Definitely, I'm going to point this out to you. You can
Uh-huh.
see for the lower percentiles, you can see that they have the new curves that are sort of dotted, and the third generation, which are the old curve, with the second generation, sorry, the old one are dots, and the third generations are solid line. So you can see here that it's actually much smoother,
Uh-huh.
and we
Like
were
a
expecting.
steeper curve.
Absolutely,
Yeah.
absolutely. It looks like for babies that were born between 24 and 30 weeks, we were tolerating in the lower percentage some much smaller weight.
We were letting them just ride out
Yeah.
nutritionally
The rest
deficient.
and the rest match up pretty
Yeah.
evenly. So
Yeah.
we're gonna post this. We're gonna post this on YouTube and on social media so people can see, obviously, and you should consult the paper. Another thing is the growth velocity trends. So they saw that the growth velocity declined steadily from 22 to 50 weeks, meaning that the curves actually get quite flat across all percentile. Weight gain decreases from 21 grams per kilo per day between the weeks of 22 to 27 weeks to just under 6 grams per kilo per day by 49 weeks. Head circumference as well growth is declining from 1.1 centimeter per week early on to 0.3 to 0.4 centimeters per week later on in the neonatal period. And when we're looking at length, same thing, growth dropped from 1.5 centimeters per week down to 0.7 to 0.8 centimeters per week by 49 weeks. And that was a consistency that was observed at the same time in the 3rd, 50th, and 97th percentile for both sexes, confirming that the chart represent probably a more proportional, predictable growth across gestational ages. What's also interesting is that there's an agreement between the growth and the fetal ultrasounds estimate. So the new growth curves, were compared with established fetal growth standard like the Hadlock, the WHO, or the Nicolaides, which I was familiar with the WHO, but not much more of these other fetal ultrasound estimates. But the 50th percentile of the Fenton charts aligned actually quite closely with the fetal ultrasounds estimate across gestation, really going back to that goal of making sure that we're trying to match fetal growth after preterm delivery. And so I think that's a big deal. The conclusions are that these, according to the authors, that the 3rd generation Fenton growth curves provide a more accurate, a more normative representation of preterm growth by focusing on preterm infants without abnormal fetal growth. I think that's key that they remove these infants. These growth charts show improved growth velocity patterns across the percentiles and closely aligned with ultrasound estimate of offering a standard for monitoring preterm growth. If you are like me and you rely on the terrific website called PD Tools to do like some of these growth estimates, they've already updated the website to actually include these new curves. So you should be in good hands. But if you are plotting these manually in the unit, in those binders, then it's time to print the new Fenton growth curves.
I know, that's what we're doing, right? In 2025, our
Listen, my
paper
friend,
growth
we
charts.
used to round with that little tray with
Yeah,
all the binders and we used to plot the babies. And
that's
I'm
right.
telling you, this was actually very valuable for
I
me to do. I
totally
remember
agree.
we were putting that, you had to put that dot on the
Yeah,
curve
then you could
and you
really see it in real time, you know?
you really appreciate it
Yeah.
exactly with the
And
yeah.
I think
So
it's such a valuable tool for families when you're rounding and you have the growth chart
yeah,
there, you know?
we have the luxury in our unit to have a dedicated neonatal dietitian. It's a luxury. We are This is not lost on us, and the opportunity that our dietitian Rebecca, if you're listening to the show, hello. Um, she's able to sit down with parents and go over the growth curves and show them the progression and what justifies a little bit some of the nutritional adjustments we're making. I mean, parents love it. The idea to actually do something that they regularly
For
do at the
sure.
pediatrician in the NICU is a big deal. And sometimes it's hard for us as neonatologists to find the time to sit down with as many parents as possible. So, yeah.
Yeah, if you're lucky enough to have a Rebecca, then good for you.
Yeah.
Good for you.
Get a Rebecca.
Get a Rebecca. That's the take home point here. You can get the new graphs or you can get a Rebecca. Okay, well, I thank you for sharing that. I am gonna do an article that you actually highlighted for me. So I am it's in the Journal of Pediatrics. It's entitled Retinopathy, Prematurity, and Risk of Structural Brain Abnormalities on Magnetic Resonance Imaging at Term among infants born at less than or equal to 32 weeks of gestation. And now you know everything that the paper's about. The lead authors, Shalini.
But the association is not something you would expect. So I think it's
That's
actually
right.
quite intriguing because
That's
it
right.
makes you want to dive into the
For
paper.
sure. For sure. They did a good job of roping us in here. Lead
Mhm.
author Shalini Roy, senior author Nahal Parikh. This is the Cincinnati Infant Neurodevelopment Early Prediction Study, Synapse investigative group. So I thought this was actually really interesting. There has been a lot of discussion, some good animal studies about retinopathy of prematurity and neurodevelopmental outcomes. So, like, are they associated? Does one cause the other? Is it part of this kind of abnormal maturation? A lot of hypotheses. So, basically, what they wanted to do in this study was to determine if ROP and severity of ROP is associated with brain abnormalities on MRI at term equivalent age in infants born preterm. So we'll just jump right in. It was a prospective cohort study of 395 infants born preterm between September 2016 and November 2019. Gestational ages range from 23 and 0 to 32 and 6/7 weeks across 5 NICUs. Infants were excluded if they had a chromosomal or congenital abnormality affecting the central nervous system, if they had cyanotic heart disease, or if they were still hospitalized and mechanically ventilated on more than 50% oxygen at 44 weeks postmenstrual age. All infants underwent routine ROP screening per guidelines, and then patients were classified into different groups as either having no ROP, any ROP, which is stages 1 to 5, or severe ROP, so stages 3 to 5, or type 1 ROP, the most severe form, requiring treatment. And all infants subsequently underwent brain imaging at 39 to 44 weeks postmenstrual age at Cincinnati Children's. They looked at kind of the brain abnormalities using the Kitakoro Global Brain Score. So there are a number of global brain scores now being used for kind of exactly this MRI evaluation of abnormalities. So, if you're not familiar with the Kitakoro score, it's a composite score using the summation of abnormalities in 4 different subcomponents. So they use the cortical gray matter, the cerebral white matter, the deep gray matter, and the cerebellum. And each subscore can get a score from 0 to 4. And then basically the score is additive to get your total score.
So a
Okay.
score of 4 is not good.
So, well, you could have 0 to 4 in each of these categories.
Right.
But I mean, technically you want a 0, right? You don't want
Right.
any
The higher
score.
what I'm I
Yeah,
guess
the
I'm
higher the
I
score,
misspoke,
the
but
more
the higher the
concerning.
score, the worse the degree of
For sure,
brain
for sure. And again, like, I mean, you were correct though, because you really want no score. So the normal is kind of 0 to 3. They use mild as 4 to 7, moderate 8 to 11, and severe a total score greater than 12. And that has also been associated with long-term neurodevelopment problems. They also looked at a number of confounding variables that are known to be associated with ROP and brain abnormalities. So they kind of assigned these as part of their multivariable analysis. So they looked at chorioamnionitis, hypertensive disorders of pregnancy, pregnancy-induced hypertension, antenatal smoking, and gestational age. They also looked at a bunch of neonatal comorbidities. So and known white matter injury or abnormalities on early head ultrasound, so less than 1 month. So basically, if you had grade 3 IVH, if you had periventricular hemorrhagic infarction, if you had cystic PVL already, or if you were small for gestational age, less than the 10th percentile, neck, SIP, or postnatal sepsis. Okay. So lots of things that they were trying to bring into the multivariable analysis. So they had 495 infants consented between 32 weeks and 34 weeks postmenstrual age. They had 395 infants complete the MRI study successfully. So 66% of the total cohort had no ROP. 33.9% had any stage of ROP, and 19 babies, 4.8%, had severe ROP. Of the infants with severe ROP, 3 received retinal ablation therapy. 6 received an anti-VEGF drug, and 1 received timolol eye drops. No babies required the scleral buckle or vitrectomy, thankfully. So then they wanted to look at ROP and the global brain abnormality score. But I did want to just highlight, so there were differences between the 2 groups that had no ROP and that group that had any ROP, um, when they were looking at all those factors. So, for example, babies with no ROP had 10% choreo compared to 20% choreo, 22% choreo in any ROP. Gestational age certainly played a role. So, babies who were younger were more likely to have any ROP compared to no ROP. Um, and then the other biggies, so early white matter injury on early head ultrasound. So 5% seen in those babies with no ROP compared to 18% of those babies with any ROP. Postnatal sepsis, 5% in babies with no ROP and 22% in babies with any ROP. Finally, neck or SIP as a kind of composite. No ROP, only 3% of those babies, and any ROP, 10%. So there were differences. The babies who had any ROP had more of these obviously associated risk factors. So I just
Yeah,
wanted to highlight that.
it's obviously a problem because ROP is a marker of disease severity in
Correct.
general.
Yeah.
So to tease both things apart,
Uh,
it's not easy.
No, it's not. It's not. But I think they did a good job of identifying those characteristics and then obviously trying to account for them. So
Hmm.
they looked at this multivariable model, showed that the presence of any stage of ROP was associated with a 1.5 point increase in global brain abnormality score. And I told you 0 to 3 was normal, then higher than that gets you into mild. So basically, that got you 50% of the way between any kind of level of severity. The presence of severe ROP was associated with a 2.3 point increase in brain abnormality score. And then in the secondary multivariable analysis, so they looked specifically at those infants born less than 30 weeks gestational age, at about 210 babies. Any ROP was no longer significantly associated with global brain abnormalities, but severe ROP remained significant. And then in a number of sensitivity analyses, they added in they added in the sex and outborn status, and it did not meaningfully affect any of the relationships. And then they wanted to look at the global brain abnormality scores in general. So, any ROP and severe ROP exhibited a significant relationship with deep gray matter and cerebellar subcomponent scores. The presence of any stage of ROP was associated with a 0.7 point increase in deep gray matter score and a 0.5 point increase in the cerebellar score on the MRI at term equivalent. Now, severe ROP was also associated with deep gray matter. So it increased to a zero point 0.9 point increase in deep gray matter score and a 0.9 point increase in cerebellar score. Interestingly, neither NEROP or severe ROP were significantly associated with total white matter or cortical gray matter scores. So I thought this was very interesting because those are areas where we see babies often affected, especially with intraventricular hemorrhage, things like that. So I thought that was very interesting. So um, that's pretty much what they wanted to tell us, that obviously these associated factors, choreo, decreased gestational age, sepsis, neck, and SIP are all associated with ROP. And having ROP did appear to have increased brain abnormalities. And if you had severe ROP, even more so. So very interesting. But yeah, it's we still don't know, is it the chicken or the egg kind of thing? But certainly predicts that there was or explains that there was a lot going on with this
Yeah,
baby.
it's interesting. I mean, obviously, it's interesting that yeah, ROP is not benign.
No.
Um, and so I think that alone is very interesting.
Mhm.
Um, very cool. I guess I have time before we go for our EB Neo segment, um, to go and maybe review one more paper. I guess let me see. Yeah, we can probably do this one now. The next article, I mean, I'd like to review. I've mentioned it on social media. It's looks at the deferred cord clamping with high oxygen in extremely preterm infants. And so I think it's an important and involving question in neonatal resuscitation, which is what is the optimal concentration of inspired oxygen that we should be using during deferred cord clamping or DCC, as it is often known in extremely preterm infants. And neonatal resuscitation guidelines currently recommend initiating resuscitation of extremely low gestational age neonates, often known as LGANs, with about 30%, 21 to 30% oxygen to minimize the risk of oxygen toxicity. But the problem, I guess, that has been created in recent years is that we have adopted more and more the practice of doing delayed cord clamping. And so there is a delay of administering any form of oxygen to these babies during the time of delayed cord clamping. Data from NICUs in California, where resuscitation typically begins with 30% oxygen, shows that infants with low oxygen saturation are at increased risk of death or severe IVH, and for the combined outcomes of early death and severe IVH. Now, there's a meta analysis of individual patient data of less than 32 weeks, which we reviewed on the podcast, that have found lower mortality rates in those resuscitated initially with high oxygen saturation. Now, the body of evidence prompted ILCOR, the International Liaison Committee on Resuscitation of Neonatal Life Support Task Force, to suggest that it is reasonable to begin resuscitation of infants born preterm before 32 weeks of gestation with a relatively higher oxygen concentration. And the reason this matters is because during delayed cord clamping, the use of 100% oxygen may actually support pulmonary vasodilation without inducing systemic hyperoxia as the pulmonary venous return mixes with the umbilical venous blood. And this could enhance pulmonary blood flow and oxygenation. While we know that delayed cord clamping is known to reduce mortality, the lack of effective breathing before cord clamping remains a risk factor for poor outcomes. And so I think that that's what we were talking about this window that has sort of opened up with the acceptance of delayed cord clamping as really a measure of quality. Physiologic evidence suggests that to overcome hypoxia in this particular population, we may need both positive pressure and high oxygen. So this study aims at the evaluation of whether using 100% oxygen during delayed cord clamping in infants that are born between 22 and 28 weeks would reduce the incidence of hypoxemia by 5 minutes of life, defined as having a saturation of less than 80% when compared to the use of just 30% oxygen. It also looked at the safety and feasibility of delivering that, because we'll talk about this. How do you deliver oxygen during delayed cord clamping, especially when we're dealing with C-sections and so on? So we'll talk about that. This was a study. First author was Dr. Anoop Kathiria, who's been on the podcast before. It's a double-blind, randomized clinical trial involving preterm infants born between 22 weeks and 0 days and 28 weeks and 6 days at birth. The study was conducted across hospital centers in California from November 2021 to October 2024. The participants were randomized prior to the delivery into one of two groups. One group received 90 seconds of delayed cord clamping in 100% oxygen. This was considered the high oxygen group, while the other received just 30% and was known as the low oxygen group. Both groups received respiratory support via mask CPAP or positive pressure ventilation during delayed cord clamping, and they were using Neopuff, which I think we're all using at this point. They had some form of blinding where they basically covered some of the settings on the Neopuff, and that's really it. There were several exclusion criteria. I think pregnancies with membrane rupture before 20 weeks, monochorionic twins with twin-to-twin transfusion syndrome, placenta creta, known congenital anomalies, etc. So they had this bed called the Life Start bed, which is basically kind of like a table where you can actually perform the resuscitation on and do this at the bedside. And they had like a chemical warming mattress, sterile drapes, and this bed was set up prior to delivery in a sterile way. They put the CPAP oxygen tubing in a sterile sleeve, and they basically set up everything for the delivery before before the OB even begins. Infants remained attached to the umbilical cord for a total of 90 seconds, and they provided stimulation, just like neonatal resuscitation recommendations state, and followed by CPAP for approximately 60 seconds. No changes were made to the oxygen concentration or pressure setting during the intervention. After the cord was clamped and cut, then the infant was sort of taken physically to a separate warmer, where then resuscitation continued. The initial setting on that warmer was always set at 30%, and then it was up to them to decide to titrate up or down. The primary outcome of the study was to look at the incidence of hypoxemia at 5 minutes of life, and that was defined as having SATs below 80%. They had a lot of exploratory outcomes that they looked at, and it included heart rate, oxygen saturation in the first 10 minutes, need for intubation in the delivery room, need for surfactant, need for chest compression, need for epinephrine, duration of hyper or hypoxemia. They looked at cerebral oxygenation. They looked at hemodynamic support, several short-term morbidities like IVH, neck PDA, and bronchopulmonary dysplasia. So looking at the results, a total of 140 infants were included in the study, 68 in the high oxygen group, 72 in the low oxygen group. The average gestational age was 26 weeks. And because it was a prospective randomized study, the baseline characteristics are pretty well matched. For the primary outcome, in the low oxygen group, 39% of the infants achieve saturations of 80% or higher by 5 minutes. And that was very low compared to the high oxygen group that reached SATs of 80 or above by 5 minutes in 69% of cases. So a 30% difference between the two groups. This yields an adjusted odds ratio of 3.74 with a 95% confidence interval of 1.8 to 7.8 and a p-value of less than 0.001. Let's look at some of the secondary and exploratory outcomes. The time to reach SATs of 80% was shorter in the high oxygen group, 4 minutes versus 6 minutes. The mean oxygen saturation in the first 5 minutes was 69% in the high oxygen group versus 67% in the low oxygen group. The heart rate in the first 5 minutes was similar between the two groups. The proportion of infants breathing before the cord was clamped was comparable, and the rates of CPAP and PPV before and after cord clamping were similar between the two groups. In terms of delivery room interventions, intubation occurred at a similar rate, 38 and 39%. Surfactant administration, I would say, were also similar, 24 and 28%. A few infants required chest compression and epinephrine. 2 in the high oxygen group received chest compression, and 1 received epinephrine. None in the low oxygen group received these interventions. In terms of NICU outcomes, severe IVH occurred in 3 infants, in the high oxygen group, 6 in the low oxygen group. The death before 40 weeks was similar between the two groups. Grade 2 to 3 BPD was lower in the high oxygen group, 22% versus 39%. Again, not so statistically significant that we can actually make a recommendation on that. PDA requiring pharmacological treatment, 31% in the high oxygen group, 44% in the low oxygen group, and the rates of neck, late onset sepsis, ROP requiring surgery similar between the two groups. There was no significant difference in cerebral tissue oxygenation or systemic hyperoxia during the first 10 minutes or the first 24 hours of life. Importantly, despite the transient use of this 100% oxygen, there was no signal of increased systemic oxygen exposure, hyperoxia, or associated complication. And so the authors then conclude that the use of 100% oxygen during delayed cord clamping significantly reduced the incidence of early hypoxemia without increasing systemic hyperoxia or the risks of adverse outcomes, and that these findings, according to them, support the potential revision of resuscitation guideline to incorporate higher oxygen concentration during delayed cord clamping for extremely preterm infants, and that further larger multi-center trial are warranted to validate the results and to look at short and long-term outcomes associated with this particular approach. Whew. It's happening.
It's exciting.
We're going to get into that. We are going to get into that sterile field.
Actually, the other night, in the middle of the night, I attended a C-section. I was like, oh, I'm so glad I don't have to gown up.
Seriously.
But if it helps the babies, then we'll do it.
All right, we're going to take a quick break, and then we will be back with Robert Dietz from the EB-NEO community to review the paper that we've talked about already on the podcast, but has made the round about whole body hypothermia for neonatal encephalopathy in babies born between 33 and 35 weeks. Stay tuned, and we'll be right back. Okay, we are back today for a new EB-NEO segment. We're always happy about our partnership with the EB-NEO community. that identifies an article, a manuscript that is most likely to impact clinical care, and members of their team devote a significant amount of time reviewing that paper and writing a thorough commentary. We are joined today by Dr. Robert Dietz. Robert, welcome to the program.
Hey, thanks, Ben. Glad to be here.
Robert is a neonatologist from the Department of Pediatrics in the University of Colorado in the US. Um, Robert, you're reviewing for us today a paper that has really made the rounds, it's created a lot of buzz. It's a paper published in JAMA Pediatrics called Whole Body Hypothermia for Neonatal Encephalopathy in Preterm Infants 33 to 35 weeks gestation, a randomized clinical trial. We reviewed this paper on the podcast prior, but for the people who are a little bit can't remember the details of the trial so much, can you tell us a little bit what is your cursory review of the data presented by this paper?
Yeah, sure. So these authors, they compared uh, whether babies who qualified for neonatal encephalopathy between 33 and 35 weeks, um, who met criteria for therapeutic hypothermia based on sort of, pretty standard HIE criteria. And they compared whether or not therapeutic hypothermia, which was initiated less than 30 or less than 6 hours after birth, compared to babies who were not cooled, if that led to reduced risk of death or disability at 18 to 22 months. This was a randomized control trial. Um, and they ended up using about 88 to 90 patients in this trial. I think, as far as demographics went, that the two groups were pretty equal. Um, I think the main thing that caused a lot of buzz um, in the field was really the 35 weekers. Um, so they showed in 33 weekers that there was an increased signal for death, and um, for the babies who were cooled, that was certainly also shown in 34 weekers. And then in 35 weekers, they had a total of 48 patients, 28 randomized to hypothermia, 20 randomized to normal thermia. And they showed that about 25% of the babies who were cooled at 35 weeks to 35 and 6/7 um, had died, compared to 20% who were treated with normal thermia. And there's also a small signal for um, death alone. So that the 25% versus 20% was death or moderate to severe disability. And the death alone was 18% for hypothermia and 15% for normothermia.
Yeah, no, I think that this is a great review. I think the paper ended up, like you said, it's a randomized trial, so they did have 88 babies in that hypothermia group, and they matched them to 80 babies in a normothermia group, and I think that one of the things that they did was, which was interesting, was this sort of Bayesian approach, where basically in the paper they were able to present the information in terms of relative risk with confidence interval, but basically give you a probability of benefit versus a benefit and a probability of harm. And what was interesting was that the probability of harm for the primary outcome, which you mentioned, is a combined outcome of both death or moderate to severe disability, was something like 75%. And then when they broke down that specific outcome to mortality alone, the probability of increased death was about 87%, with a probability of benefit of 13%. And I think that you're right. I think that one of the tables, that it's rare that the supplemental material gets so much publicity.
Right.
But one of the things was that in that supplemental material, the table 2 broke down the outcomes by gestational age. So basically they had basically 3 lines, because they were looking at 3 weeks of prematurity, 33, 34, 35. And they were looking at both the difference in terms of death or moderate to severe disability versus death alone. And what you could see was that the rates of the rates of death were much higher, specifically in that 34th week. It was kind of the same in the 33rd week. There were very few babies. And it was kind of similar in the 35 week, as you mentioned, because 35 week was one of the gestational ages where we thought, hey, maybe we can cool these kids. um, but it's unclear at this point that this paper will encourage the therapeutic creep that we've seen up until now. Um, I'm just the commentary that you wrote is now up and available on Acta Pediatrica, like every EBNEO commentary. But I'm just curious about what were some of the takeaways that you highlighted from this particular paper in terms of clinical practice?
Yeah, I think that even compared to the creep that you talk about, it's actually an AAP guideline to cool 35-week babies and above. So it's not even creep; it's actually in the guidelines to cool these babies,
You're
which
right.
I think is what's caused so much interest in this paper. Um, and interestingly, in Colorado, we changed our criteria from 36 weeks to 35 weeks for inclusion for hypothermia back in 2016. That was based on some of the data from the ICE trial, which included down to 35 weeks. Um, I think some of that data is what the AAP um, used for their recommendations. And I think, as you highlighted, the one of the big parts of this paper, the more important parts of this paper is how they broke it down by gestational age, which really hasn't been done previously in the big hypothermia trials. And when the authors for this paper, the whole body hypothermia for 33 to 35 weeks, went back to look at the data, the ICE trial only included, I think, 7 or 8 babies. And so sort of the whole field sort of shifted based on really was a couple of babies that wasn't really clear from the ICE trial. Um, so I think, a couple of things to think about is, why are some of these late preterm babies, why are they at higher risk potentially um, for increased death or moderate to severe disability? And there was some papers back in the 60s that showed, we're all aware of this in neonatology, that keeping babies warm is better, right? We go into the delivery room, we increase the temperature, and part of that's because of immature epidermal barrier and higher ratio of surface area to birth weight than term infants, which could contribute to a higher cold stress and then leading to more mortality and morbidity. Um, and I think one of the other things that hasn't gotten a lot of discussion about in terms of some of the other data in this paper is if you also look in the supplementary data, there's a little bit of information about how well they were able to cool these babies,
Uh-huh.
meaning that the babies that were randomized to hypothermia, actually about 35 to 40% of those babies, of those 88 babies randomized to therapeutic hypothermia, were overcooled. They went down below 32 degrees.
Yeah,
Um,
they got
so
too cold. Yeah.
yeah, so and they were using a little bit older system. They were using the plate control systems, which I think a lot of units don't use anymore. We use more servo controlled um, hypothermia systems now.
And importantly, I think that's important to mention that there's been significant amount of data showing that overcooling is not good. It's actually harmful, and
Yeah,
that's why you want to keep babies in that tight window, and that's why you're bringing this up because obviously overcooling could that have contributed to the increased incidence of
and
negative
that's true
outcome.
across all gestational ages, even the
Yeah,
full term babies
yeah,
that we
yeah. You're
use
right.
for,
Yes,
right?
absolutely.
So I think when I talk to a lot of, I focus on neuroscience. So I have a PhD in neuroscience. I'm very interested in these groups of patients, and um, a lot of groups now are rethinking where they are, what their cutoff is for hypothermia, whether that's to keep it at 35 weeks, go up to 36 weeks. And I think a lot of people, based on this data, have adjusted their criteria to only include babies 36 weeks and above for therapeutic hypothermia. Um, and that really talks about like whether or not AAP recommendations, which we talked about a few minutes ago, need to be reevaluated. I think they are reevaluating it right now. But, we take all this data together, we're talking about specifically the 35 weekers, we're talking about 25 babies in one arm, 20 babies in the other arm. It's still a very small number. There may have been some issues with the temperature, um, in some of these babies. You know, I think the question is, where do we go from here?
Yeah,
Right. Uh, in Colorado, we have decided to continue to cool 35 weekers above until the AAP changes their recommendations or until more data comes out. I'm part of the Children's Hospital Neonatal Consortium, and we're starting to look at this. We have huge numbers of babies, over you know, a few thousand babies who have been cooled over the last 15 years in our database. And we're going to be looking at this, it'll be retrospective, not as well controlled, um, but to really kind of help the field figure out where we should go with the data from this paper.
for sure. I think that you've said so many things. Number one, I know that the CHNC is looking at therapeutic hypothermia very closely, and the work you're doing with the rest of that group is quite interesting because what we've learned is that every step of the process matters. How long does it take you to cool? Whether a baby being cooled within 1 hour is the same as a baby being cooled at 5 and 55 minutes.
Yeah.
Um, I think that we start to understand it a little bit better. And like you said, this division of the different gestational age, especially if we just look at the 35-week group, we're talking about maybe 50 babies total in both arms, 28 babies in that hypothermia group. So it's difficult to know, like, is that enough to swing the pendulum back in the other direction? What I really appreciated about your commentary is that a lot of times we get this data and we look at the numbers a little bit dubiously and say, okay, well, that's the data. That's what the data shows. But you actually took a stab at trying to understand a little bit potentially whether there's a physiologic basis for what the authors found, talking a little bit about the immature epidermal barrier and the high ratio of surface area to birth weight compared to term infants, and maybe that cold stress actually is something that contributes to the increased mortality and morbidity. I thought that was very interesting to look at it in those terms because I read your commentary, and then you think, well, maybe then the target should be different, or maybe we can look at this, but in a more physiologically oriented manner. Do you think that we'll have in the future different sort of hypothermia protocols for babies that are late preterms versus full terms?
Yeah, I mean, there's always a lot of interest in all these, like, different areas. There's a lot of interest in, like, these late preterm babies. There's a lot of interest also in mild HIE, and so I think a lot of thoughtful people are examining how to think about these babies that are a little bit outside of those original randomized control trials. There've been several now, as you
Yeah,
know. Um, so looking at mild HIE, looking at these preterm babies, and whether we should really be thinking about these babies sort of more, in a more targeted way.
for sure.
I think that certainly could be a way to go in the future.
Yeah, especially because they're different. Their tolerance for acidosis is different as you go further and further back in gestational age. We know that a 23-weeker tolerates acidosis very differently than a 39-weeker, and I think that maybe that should enlighten a little bit our approach to how we manage acidosis at the time of birth, depending on the gestational age. So I think this is very interesting. You do have some references there as well. Dr. Laptook is all over these references.
Yeah, exactly.
He's the guy. But yeah, so it's a very interesting commentary. Thank you for sharing that with us and for coming on the podcast to share your thoughts. The commentary is called "Is Therapeutic Hypothermia Beneficial to Infant Born Between 33 and 35 Weeks of Gestation?" You co-wrote this commentary with Harissa Spihik and Sandra Zubovsky. Thank you, Robert, and for your time and for this
It's been a
commentary.
pleasure. Thank you, Ben, for inviting me.
All right, we are back for the last half of Journal Club. Daphna, where are you taking us next?
Well, I'm taking us to another exciting area of, let's say, area of opportunity. And this was in JAMA Network Open Pediatrics. Um, Early neurodevelopment of extremely preterm infants administered autologous cord blood cell therapy. This is a secondary analysis of a non randomized clinical trial, the Cord Safe study. Lead author Lindsay Zhao and senior author Atul Malhotra. So, lots of exciting new studies about stem cell therapy um, coming from down under. So basically, what they wanted to do, they did the Cord Safe study, which was basically a pilot to look at kind of safety outcomes for preterm infants receiving autologous, so their own cord blood stem cells. Um, and then they wanted to do kind of a short term follow up and looking at what they're calling early neurodevelopment. So the babies, let me let me tell you what they were doing. Okay. So again, it was a phase 1 trial, the Cord Safe study. They want to look at feasibility and safety of this cord blood cell infusion, which we have discussed previously on the podcast. So the babies they enrolled were extremely preterm infants born before 28 weeks gestation and surviving at least 2 weeks of postnatal life. Parents obviously had to consent to participate. And this is an important key. They had to have had adequate good manufacturing practice grade autologous uh, umbilical umbilical cord blood cells. So they take the blood cells and then they look at them and they do all these analyses of them and make sure they're like high enough quality to be used for infusion. And then the infusion, I'll get into those details. But
Yeah, that's a big concern. Like,
yeah,
it's not because you have stem cells that
that
they're
they're
good
good.
cells.
That's right. So
They could be bad cells.
yeah, so it's actually and we described this, maybe we can find the episode number, but, the Cord Safe, study and all the details that they looked at to make sure there were enough stem cells and that they were high enough quality. Um Let's see. Infants were excluded if they were outborn, if they had less than 7 mLs of cord blood collected because they wouldn't get enough stem cells. If they did not have GMP, the good manufacturing practice grade cord cells. If they had severe IVH reported by the day 8 cranial ultrasound, or if they had culture positive sepsis within 48 hours of the planned infusion. Now, if the infant met all of the inclusion criteria between postnatal days 9 and 15, then they were eligible to get the autologous blood cell, UCBC, umbilical cord blood cell infusion. And so basically, they bring it, they clean it, they wash it, they mix it up, and then they get a final volume of 10 mLs per kilo. And that's what they use for the infusion. And they give us a little bit of detail about how the infusion works. I'm not going to get into that right now. But they used a kind of contemporaneous cohort as kind of their control. So they had non kind of randomized similar infants. And this cohort included all infants born at less than 28 weeks gestational age during the study period that were not enrolled in the trial. They used the very same exclusion criteria. So outborn severe IVH on by the day 8 cranial ultrasound um, and moving forward. So the outcomes that they wanted to look at, and that's why they're calling it early development. And so this is not a long-term follow-up yet. They were using the term equivalent age MRI brain scan. So basically, the babies got to term, they got these MRI brain scans. We actually spoke about the Kitakoro brain injury score, and they used the same score. So we talked about that in 2 studies ago. But basically, the reminder, the Kitakura score looks at sub-scores of different brain areas, and then they use their additive to they sum it for a global brain injury score. And as a reminder, normal 0 to 3, mild is 4 to 7, moderate 8 to 11, or severe greater than or equal to 12. They also did some early neurodevelopmental assessments. So they use a general movements assessment. They use the Hines, the Hammersmith infant neurological exam, and they did the hearing test. So they did all of those at a postmenstrual age of 52 to 54 weeks. And they highlight, and I think this is important to note, when the MRI, the GMA, and the Hein are all outside the reference range and they're concerning for cerebral palsy, the sensitivity for detecting cerebral palsy is 98%. So, we've talked about this before. We can screen for cerebral palsy near discharge and, give parents some of that information. But they're highly predictive, especially all taken together. So, the group, so it's a small group, it wasn't powered to detect any changes in neurodevelopment. It was really just a pilot safety trial. But the number of infants who received cord blood infusion were 23 infants. The median gestational age was 26 weeks. The median birth weight was 748 grams. The contemporaneous group had 93 infants, a median gestation of 26 weeks, median birth weight of 769 grams. I think there's some details about the umbilical cord group. Were they on respiratory support? Yada yada yada. But we'll skip that for now. Okay, you don't need to know all that information right now. There was one death after enrollment in the umbilical cord blood cell cohort, felt to be due to bacterial sepsis, not felt to be related to the infusion. There were 2 deaths in the contemporaneous cohort. So the median MRI brain injury score was 2 for the cord blood cell group and 3 for the contemporaneous cohort. The adjusted analysis, though, revealed no statistically significant difference between the groups. And for both groups, the global MRI brain injury scores were in the normal or mild category. And brain structure measurements between the 2 groups were also not significantly different. Now, in terms of the developmental assessments, so the median Hines score was 57, and the umbilical cord blood cell group, and 59 in the contemporaneous group. So again, not statistically significant. Absent fidgety general movements was identified in 4.5% in the UCBC group, compared with 11.5% in the contemporaneous group. This was not statistically significant, even though it feels quite different. And lastly, no infants in the UCBC group were assessed as high risk for CP, while 6 of the 87, so 7% of the contemporaneous cohort received a high risk of CP diagnosis. So this was not statistically significant, but again, no babies in the UCBC group. So the discussion is that in this study that was not powered to detect neurodevelopmental differences, there were no statistically significant differences, but they are currently undergoing subsequent follow-up. So these study participants will get the standardized developmental assessments at age 2 to 3 years using the Bailey 4th edition. And that study is called, where is it? I will tell you.
You will find it.
The cord cell randomized
Mhm.
control trial is another next step to, again, randomize babies into receiving UCDCs or not for long-term neuroprotection.
Mhm.
Okay.
So, yeah, I really appreciate you covering this paper. I think that this is really still a frontier of
Yep.
neonatology. I think that the buzz about stem cells was probably a bit too early 10 years ago, because it was definitely far away from reaching the bedside. But I think that we are now at the point where we're going to start seeing stem cell infusion being done at the bedside. We strongly believe that this is probably the next frontier.
Yeah.
And Dr. Malhotra in Australia has been right there in Australia.
Hmm.
Might not, yeah, have been, I guess, at the cutting edge of a lot of the stem cells work. We took a lot of resources to actually bring Dr. Malhotra to Delphi this past year, and his talk on neonatal cell therapies translating promise into benefits was super interesting. He goes over basically all the different projects that they are working on, and it's quite interesting for me, at least, without getting into the details of the stem cell research, but how close they are to clinical applications. So
Yeah, and this is just one of the clinical applications, right? I think the
yeah,
next steps are the babies who do have IVH and the babies who have HIE. I think there are lots of
exactly.
opportunity.
Yeah, and he's mentioned the Court Safe trial
Yep.
during that talk, and the use of umbilical cord blood cells for preterm lung injury,
Mm.
and basically he goes over all the different trials they're involved in. So it's very, very interesting. I think that this is always an interesting aspect of Delphi. This year we'll have Dr. Bernard Thibault from Toronto, Canada, to come talk to us a little bit about updates on stem cell therapy. But I'll link Dr. Malhotra's talk on stem cells in the episode show notes. It's 20 minutes. That's the
Mhm.
length of every Delphi talk. It's a very easy watch. The quality, you can stream it in 4K on your home TV. So yeah, really a great talk. And his wife is an OB, so she was there. She also gave a talk, different talks. If you're interested in that, you can find it as well.
Yeah, they were great. They both gave 2 very different, but very, very
Very, very
captivating
different
talks.
personalities as
That's
well.
right, yeah.
Yeah.
They're opposites attract, but
He was
they're
very much,
delightful.
he appeared as this introverted sort of bench
Mhm.
scientist on stage, even though he's very eloquent and the talk was really good. And his wife was so extroverted. It was such a performance.
Mhm.
She's an obstetrician, so anyway, you guys can go take a look at that.
Oh, no, but we were very lucky to have them both. That was a
Yeah, thank you.
highlight
If you're
for
listening, thank you both
yeah,
again for coming to
Delphi
Delphi. That was
2024 for
fun.
sure.
The talks were very successful. Okay. I guess my last paper for today is also coming from JAMA Peds, and it's a paper called Diaphragm Position on Chest Radiograph to Estimate Lung Volumes in Neonate. I was very interested in this particular paper. The first author is Sophia Dam, and the introduction is very interesting because it talks about how many of us in neonatology have accepted the routine clinical practice of using the diaphragm position on the chest radiograph to assess basically lung volume. How many times have you looked at a chest X-ray and counted the ribs
I
and be
counted them
like,
today.
"Oh,
Yeah,
it's a hypoinflation,
100%. Yeah,
hyperinflation." What?
I counted them today multiple
Yeah,
times.
I do it all the time.
That's right.
Now, and it's funny because the introduction
I
talks about
almost
this,
felt
and
a
then,
little offended with this intro. I think like, yeah,
well,
okay. So you
we'll
show me
talk
what
about it
else to
because
do. Yeah.
yeah,
That's right.
um, and this approach of counting the ribs, the number of visible posterior ribs to estimate aeration, has been part of our toolkit for over a century and is embedded in numerous NICU guidelines. And typically, 7 to 9 ribs suggest normal aeration, fewer than 7 hypoinflation, and if you're over 9 ribs, it's hyperinflation. I do this all the time, by the way. I'm not being judgmental. I count ribs several times a day on a lot of babies. However, despite the widespread sort of nature of this practice, it's never actually been validated in infants. In fact, there's only one small study previously that looked at this question using gas washout and that found no meaningful association. Because methods like spirometry and plethysmography are too invasive or complex for the use at the bedside, many have defaulted to the use of the diaphragm position as a simple sort of heuristic. But how reliable is it? Now, the authors of this study, the Collins study, the calculation of lung inflation in neonate, set out to answer that question by comparing diaphragm position to CT images looking at derived lung volumes, a more precise method, obviously, of estimated aerated lung tissue. The primary objective of the study was to describe the association between the diaphragm position on the chest, radiograph, and CT measured total lung volume in infants. So, in terms of the method, this was a retrospective cross-sectional study conducted at the Royal Children's Hospital in Melbourne, Australia. And the investigators included infants who had received a chest CT in the first 30 days after birth. And they looked at cases between 2012 and 2022. Infants with congenital lung anomalies were obviously excluded. So, to estimate the position of the diaphragm, because you'll see that they ended up not using a chest X-ray. That's a big deal, but you'll understand that it's okay. So they used the CT topogram. The topogram is actually what they refer as this chest radiograph equivalent, or CRE, and it basically, when you look at chest CT, you guys will all remember that there's a frontal scout image prior to the CT scan. There's like one image of an AP chest, almost like an X-ray, but that's like the first image being taken by the CT scan. And while topograms differ slightly from traditional chest X-ray in terms of image resolution and technical factor, they're considered reliable for assessing diaphragm and rib anatomy. And this was done so that the image that they took was as close as possible in proximity to the actual chest CT images that they were going to collect right after. So that was actually quite clever. They didn't have to expose the baby to yet one more X-ray as they were doing this. The position of the diaphragm was defined using a standardized approach created by a group of experienced neonatologists and pediatric radiologists. And essentially, they identified the last posterior rib that completely intersected the diaphragm or contained it entirely. They have this in the supplemental material, where basically they show you how they counted. If the diaphragm was between ribs, then they applied a rule based on how much of the intercostal space was filled with lung fields. Now, lung volumes, were then calculated from the actual CT scans using a semi-automated segmentation tool that is done on the Singo software, which is a software we use for radiology reviews. And lung volume was standardized to body weight and expressed in milliliters per kilogram. The software also computed Hounsfield units, which help estimate tissue density and aeration, and the degree of lung consolidation was scored subjectively as either none, mild, moderate, or severe. If any scan had poor quality, for example, if more than two planes were missing, the lung, or the diaphragm was not visible, the study was obviously excluded. The investigators were blinded to the diaphragm measurement and vice versa to avoid bias. And the primary outcome of that study was to look at the total lung volume associated with each diaphragmatic position, ranging from the 6th to the 11th posterior rib. And they used the Kendall's tau to test to assess correlation and define association as either weak if the correlation was below a number of 0.4. I'll talk to you guys about this in a second. So let's look at the results. Of the 292 eligible CT scan, 218 infants were included in the final analysis. The median age at the time of the scan was 11 days, and most infants were actually born at term. And we'll see that they were quite skewed towards specific pathologies. The average weight at the time of the CT scan was about 3,000 grams, and 61% of the babies had a cardiac diagnosis as their primary diagnosis, which, if you're doing a retrospective study, those kids that are going to get a CT early on at birth, they are not your routine choreo admission, obviously. So it's both interesting but not very surprising. Notably, 35% were intubated during the scan, and 61% had some degree of parenchymal lung opacification or consolidation. So as for the diaphragm measurements, the number of posterior ribs visualized on these CREs, on these initial chest topogram, ranged from 6 to 11, 95% falling between 8 and 10. In more than half of the infants, the diaphragm was located at the same rib level on both sides. However, in 35%, the left diaphragm was lower, and in 10%, the right side was lower. The discordance in diaphragm level wasn't addressed in any current guidelines, but was quite common in this particular study. So let's look at the correlation between the diaphragm position and the lung volume. And the truth is that that correlation was weak. The Kendall's tau for total lung volume versus the posterior rib number was 0.23. Looking at infants without any consolidation, it didn't really improve. The tau number was 0.3. Even when they analyzed the left and the right hemithorax separately, the association remained weak, 0.25 and 0.21. Um, in terms of, so I just want to make sure that we also all understand how to interpret these different results. So the Kendall's tau test, it's a non-parametric statistic tool used to measure the strength of and direction of an association between two variables. So basically, perfect association would have been 1, and -1 would have been perfect disagreement, and 0 means no association. The study had defined that 0.4 was going to be their threshold. So basically, all the numbers I've given you have fallen below that threshold of 0.4. So there is an association, but it's not very strong. It's actually quite weak. They were also looked at several secondary analyses comparing the Helms field unit, which indicate the lung density, and the correlation with diaphragm position was also very weak. The apex diaphragm vertical distance, another potential marker for lung expansion, had poor correlation with volume. There was no notable difference when the diaphragm position was measured from either the lower or the higher hemithorax. And the range of total lung volume at any given rib number was also very broad, from 20 to 60 ml per kilo, making it difficult to use the diaphragm position as a reliable estimator in any practical way. So the results of this cross-sectional study suggest that despite long-standing clinical acceptance, the diaphragm position as measured through the number of posterior rib on a chest radiograph is not sufficiently accurate for the use in practice as a surrogate of lung volume. And they caution against the use to guide respiratory support decision until alternative non-invasive methods are available, like maybe electrical impedance tomography. But a very interesting paper. And in the discussion, I think they talk about something that I believe is quite interesting, because it makes you think a little bit about the chest X-ray, and it makes you think a little bit about what is the information that we're getting. They're really talking about the fact that when we're looking at when we are looking at chest X-ray, we're looking at like an AP film, and so you're looking at like the degree of change in area from top to bottom. But babies are lying flat, and the expansion going from posterior to anterior is probably more important. So I'm going to quote you from the discussion. They said, fundamentally, a frontal chest radiograph is a two-dimensional coronal image of the lungs, leaving the expansion of the lungs in the anterior posterior direction unable to be examined. And the more compliant and flexible infant thorax allows greater displacement along the non-coronal plane compared with adults. And infants also perform more abdominal breathing and maintain a tonic diaphragm during respiration. And so they're saying that this highlights the many factors that contribute to radiographic appearance of the lungs at any point in time beyond the level of respiratory support. So I think, anyway, it's a very interesting conversation. I love neonatal pulmonology, so
For sure.
I think this is all very interesting.
Well, I mean, everybody's looking for ways to use different imaging modalities, right, to learn more about our patients. So it's exciting.
And remember that's why I wanted to maybe go over the Kendall's Tao's test, because it's not like they're saying that there's an opposite association. They're not saying that there's no association. It's just poor. So it's still a poor test. But if you have nothing better,
Right. What can we do?
mm, I think nobody should harm you for using it.
That's
Nobody should
right.
harm me either for using it. I'll probably continue to count tribs tomorrow.
Okay. Well, I have another diaphragm paper.
Let's do
So,
it.
my last paper today is in pediatric pulmonology. This is coming out of Japan, and they were looking at the impact of sedation on ventilator-induced diaphragmatic dysfunction in extremely preterm infants. Um, and I'm always curious as to what's going on over there. And so I thought this was an interesting study for two reasons. The first is, again, they wanted to look at diaphragmatic dysfunction. So, it's pretty well known in adult patients, larger pediatric patients, that mechanical ventilation can lead to this ventilator-induced diaphragmatic dysfunction. So basically, a decrease in diaphragm thickness or contractile strength, which can result then in subsequently this dependence on mechanical ventilation. And we kind of see that in our babies. The longer you're on on mechanical ventilation, the longer you're on mechanical ventilation. So I thought that was really interesting. The other thing that was interesting was the amount of sedation being used. And so I think in the States, we've really moved away from using a lot of sedation, especially in the very small babies, but that's not true everywhere. So, including in the States. And so I thought this was really quite interesting. So basically, what they were doing, it was a prospective observational study. It was a single level 3 unit between July 2020 and September 2023. They looked at infants born less than 28 weeks who were recruited within 6 hours of birth. They only recruited infants during working hours, so from 8 to 6. Um, and then any babies who had,
Researchers have lives too.
that's right. That's right. Good for them. Good on them. Infants who had already received sedation during their first ultrasound examination were excluded. So they do a lot of ultrasound exams over there, and so some of them apparently are using sedation for those. So you were excluded if you had already received sedation prior to being enrolled. Those with chromosomal abnormalities, major malformations, congenital lung disease, congenital heart defects. And babies who were anticipated to be extubated within the first 48 hours of life were also excluded. Um, Okay, so they talk a little bit about the respiratory management strategies in general. They try to use non-invasive modalities also. So CPAP is the first choice. They adjust it to maintain a pH of 725 to 735. They look for oxygen saturation 88% to 94%, and CO2s of 40 to 60. Now, infants were intubated for persistent apneic episodes, excessive respiratory effort, or failure to meet the above criteria. And then once the babies are ventilated, again, they use inspiratory pressures adjusted to maintain target tidal volumes of 4 to 6 mLs per kilo. And they mentioned in their unit, sedative drugs are not routinely administered to patients receiving ventilation, but when it is used, fentanyl is the first choice sedation, usually to stabilize respiratory and circulatory status. And they mentioned to prevent IVH, particularly in those born at less than 24 weeks until the first 72 hours after birth. They also use sedation where there was frequent desaturation felt to be due to agitation or when supplemental oxygen requirements exceeded 40% and were felt to be due to pulmonary hypertension of the newborn. So what were they looking for on the diaphragm ultrasound? So apparently, they're using diaphragm ultrasound with some frequency, and each baby got I think 3 diaphragm ultrasounds by different uh, by 3 different physicians, and they put the baby in the supine position. They ensure the baby is quiet, that they have regular breathing, and then they look at the right diaphragm thickness. So they measure the thickness in end inspiration and in end expiration. So they look at those 2 measurements of thickness. And they used an average of 3 measurements for each of those to come up with that quantity. So the end inspiratory is called TDI, and the end expiratory is called TDE. And they also look at this measured diaphragm thickening fraction. DTF was calculated as it's kind of like a what's it called? Like a percentage. So it's TDI minus TDE over TDE times 100%.
It's too late for me to do cross
I know.
multiplication right now.
You got this. You got this. It's fine. So basically, they obtain 1 as a baseline measurement performed after kind of the initial respiratory steps. So if the baby needed to be intubated, if they needed surfactant, once they were kind of stable, they did the first diaphragm ultrasound. And then the second diaphragm ultrasound was performed within a 24 plus or minus 4 hours because they felt like some babies would already have been developing this diaphragmatic discussion. I mean, diaphragmatic dysfunction. It's late. We're really stumbling over our words now. So, what were the outcomes? The main outcome of the study were the differences in change in the TDE over time, the TDI over time, and again in the diaphragm thickening fraction over time from day 0 to day 1. So they had 52 babies admitted to the unit. 49 of them were intubated after birth. 12 were admitted outside of working hours. 3 had major abnormalities, and 4 were extubated within 40 hours. So they had 30 patients included in the study, 13 of whom received continuous fentanyl on day 1. So that was the sedated group. And then they had 17 without sedation, the non-sedated group. So, what were the measurements? The baseline values showed no differences at day 0 between the sedated and non sedated groups. So, that's one point to make. In the sedated group, there was a significant decrease in all 3 parameters in the inspiratory, the expiratory, and the diaphragm. I can never remember this thing. The diaphragm thickening fraction. Okay. But there was also in the non-sedated group significant decrease from day 0 to day 1 in all 3 parameters as well. But when you compared the 2 groups, there were significant differences between the 2 groups, such that the sedated group had lower parameters compared to the non-sedated group. Now, I will mention that the groups are a little bit different. So the sedated group had younger babies. So the median was 24.4, and the non-sedated group, the median was 26.3. There was some differences in birth weight. So the median birth weight for the sedated group was 646 grams compared to 791 grams in the non-sedated group. So I thought that was interesting to note when we were looking at these differences. Um, they looked at reproducibility and repeatability. They had good inter-observer reproducibility in terms of those measurements. So the take home, they identified a significant worsening of diaphragmatic atrophy and dysfunction in sedated infants, indicating an unrecognized complication of sedation in ventilated preterm infants. So I thought this was interesting, both as a reminder that sedation has a lot of impacts, and two, that even just one day on the ventilator changes, the diaphragm. Something to keep in mind for babies that were keeping just one more night on the on the ventilator.
Yeah, I mean, we don't tend to appreciate the impact of the interventions that we have
Mhm.
at the organ and at the, I
Mhm.
guess, at the cellular level. So I think that's such a good point that you're making. I think this is also, I've always been bitching and moaning about the the, the point of care lung ultrasound,
Uh-huh.
but this was nice, like that. This is an application, because my point has always been the point of
What,
care lung ultrasound.
you don't like lung ultrasound?
No, I don't mind it, but I'm just thinking that the information it provides you should come, either supersede an information that was already being given
Mhm.
to me, or give me an information I didn't have before. And I never felt that um, some of the things about maybe pneumothoraces and stuff were difficult to capture before a point of care ultrasound. But this idea of looking at
You felt like you would get enough information on X-ray for a pneumothorax, for
yeah, or
example, that you didn't.
transformation,
Right.
like, yeah, this was not before point of care ultrasound. This was not something I was complaining about. But
Curious about.
this use, yeah, but use of point of care ultrasound to look at the diaphragm is interesting,
Yeah.
and And I think that how do we then tailor our
Yeah, and I
management
think I
is
think there are
is
other applications, right? Predicting extubation success, things like that. If you have more information about diaphragmatic dysfunction, is exciting.
and again, like you said in the beginning, we are making sometimes a very strong effort to not paralyze
Uh-huh.
and oversedate our infants, and it looks like this might be the right approach. And it would be interesting to see if our colleagues in Japan adjust their practice based on
Mm.
that kind
Mhm.
of data. What do you think?
Yeah. We'll have to
It's a
ask them.
pilot study,
Yeah.
but
But I mean, it sounds like they had plenty of people who were comfortable doing the diaphragmatic ultrasound, so it's definitely something they're using, so, hopefully we'll see more information coming out.
yeah. Okay, Daphne, I think that does it for us
We
tonight.
did it.
We did it. Well, this morning, because this is going to come out early morning on
That's
Sunday.
right. Don't be
Thank
confused.
you. Don't be confused. We will see you again later this week, and we have a lot more fun episodes on the Incubator Podcast. Thank you for listening, and thank you for subscribing. We will see you next time.
Bye, everybody.